Okay, good day, everyone. My name is Danny Weiss. I'm a neonatologist at Sunnybrook in Toronto and one of the co-chairs of the Neonatal Hemodynamics TnE Foundation's curriculum, along with my co-chair, Dr. Danielle Rios, who you see is our speaker today. A few housekeeping items. One, our acknowledgement and thanks to Mallinckrodt, who has provided us with an unrestricted educational grant in support of the TnE curriculum. A reminder for everyone to please use this QR code to complete the session evaluation. At the end of the talk, I'll be putting this back up. And one last plug to register and save the date for the Dr. Reagan Giesinger Clinical Cardiopulmonary Physiology for the Care of the Sick Newborn course, which is coming up in just over 2 weeks. It's not to be missed. It's a fantastic course. And it is, offering state-of-the-art hemodynamic teaching. Without further ado, it is my great pleasure to finally get to introduce my co-chair as a speaker in the TnE curriculum, Dr. Danielle Rios. She is an associate professor of pediatrics in the Division of Neonatology at the University of Iowa and interim director of the Neonatal Hemodynamics Clinical and Training Program, as well as co-chair of this seminar series. Her areas of academic focus are the hemodynamics of critically ill neonates and predictive analytics to improve outcomes of extremely low birth weight infants. She's going to be speaking today on acute pulmonary hypertension, of course, one of the very core topics in neonatal intensive care and in neonatal hemodynamics. And without further ado, it gives me great pleasure, Danielle, to hand the reins over to you. Just one final reminder that our trainees are welcome to keep their cameras off during the recording, and obviously we'll turn them back on after the talk. Dr. Rios, over to you.
Thanks so much, Danny. Do you want to stop your share so I can start? See if I can get this going. Okay, does that look good? Good. All right, well, thank you so much for the introduction, and it's been fun being one of the co-chairs and the moderators for this series, so we'll see how this goes when I'm on the other side, right? So I will be talking, as Danny said, about physiologic assessment of pulmonary hypertension using TnECHO. So I usually like to start my talks with a where are we now type of slide, but I'm usually talking about hemodynamics in general. So the field of neonatology has come a long way in the last few decades, but we still in general practice a symptom-based approach. By this, I mean that we attribute symptoms to certain pathologies, and we'll give treatment based solely on those symptoms. So the issue with this is that if we don't investigate the etiology of those symptoms, we may be treating the wrong pathology. This is all due to what it says, a lack of precision. For this talk, we are discussing acute pulmonary hypertension, so it's not really the same issue, but really the point of including my slides still is that to make sure that everybody knows we could see any of these symptoms depending on where we are in the clinical course of acute PH, so we still need to be precise and look for the etiology. So the root of the problem is maintaining adequate cellular metabolism. So to accomplish this, there has to be an adequate balance between oxygen delivery and oxygen consumption. So both are affected by various potential issues. However, in the case of acute PH, we'll be dealing mostly with an oxygen delivery problem with oxygen saturation, preload, and afterload. So why is acute PH even a problem in our population? Previous studies have shown that pulmonary vascular resistance, or PVR, takes 2 weeks to normalize after birth, as shown on the image on the left. Additionally, on the right, you can see that PVR decreases rapidly, going from low PaO2 to a normal range PaO2, but there's less change after attempting to increase PaO2 past the physiologic range. This figure depicts the differences seen in adult versus neonatal hearts. So both the left and the right ventricle are more sensitive to increases in afterload, but the right ventricle is much more sensitive to augmentation in afterload and results in a significant decrease in contractility. The other issue with our neonates is that we have an immature myocardium. So the top two images, show the lack of T tubules in the neonatal cells, which explains some of the difficulties in calcium metabolism in the neonatal myocardium. Additionally, in the lower pane, so in B, we see a decreased amount of sodium-calcium exchange, and in C, calcium ATPase pumps in the neonatal cells. Additionally, neonatal myocardial cells are also known to be less compliant. So there's about 70% of non-contractile tissue, and they're also less responsive to inotropes. So you'll often hear that neonates are unable to make change to stroke volume by affecting preload. So they must increase cardiac output by increasing heart rate. This is one of the reasons why physicians may have less concern about dopamine as a first-line agent, knowing it will increase their heart rate. However, as shown in this image, neonates, so the newborns, are unable to increase contractility or force of their ventricular contraction by increasing their heart rate, whereas even an infant, I think this was three months old, is able to do so. So this delineates the importance of identifying the etiology and choosing the correct medication for treatment. In the case of acute PH, decreased preload will be a big contributing factor, so affecting pulmonary blood flow instead of heart rate would make more biologic sense for treatment. And I added in another kind of discussion about force frequency relationship too. So along the same lines, it's important to note that the myocardium in general cannot maintain contractility in the presence of dysfunction. So the important part of this graph is right here in cardiac dysfunction. You do not have that same contractility. So ultimately, the relationship goes out the window when you have cardiac dysfunction. So this is a figure that I'm sure you guys have seen many times. It describes the many changes seen in the heart when acute PH is present, including to the right and to the left sides. What is important for what I want you to see from this is that the atrial communication, shunting from right to left, supports the preductal cardiac output, while the right to left PDA supports the postductal cardiac output. So if you have a right to left PDA, blood pressure measurements from that UAC, which is a postductal assessment, will overestimate the cerebral perfusion pressure. So now in picture format, what happens to your heart in acute pulmonary hypertension? So on the left, you start off with a normal sized left and right ventricle with a left to right PDA at the top and normal pulmonary artery pressures. In the middle picture, your pulmonary artery pressures increase, resulting in some hypertrophy of the RV and a dilated RA. And then in severe pulmonary hypertension, your RV progresses to dilation and failure. So this is kind of just the progression of disease process that we see. So taking a step back, when we're talking about neonatal pulmonary hypertension, we are not actually being specific about one etiology. So it's the pulmonary pressures are increased, but part of the assessment requires an investigation into why. So what is causing the pulmonary pressures to be increased? And the possible options include increased pulmonary blood flow, so it's over to the left. Increased pulmonary vascular resistance is what we actually usually think about and what we're used to dealing with, but that's not always the case. And then increased pulmonary capillary wedge pressure, or a left heart phenotype. So as we get to the kind of TnECHO portion of the talk, let's discuss some important considerations. So when assessing severity of pulmonary hypertension, direct measurements of the relationship between pulmonary and systemic pressures should have a greater influence on the overall assessment of relative pressure. So, for example, When present in the setting of normal left ventricular function, the direction of the ductal shunt, the ductal flow, provides the clearest assessment of this relationship as compared to something like the septal positioning. It remains important to understand that every measurement has its own limitations, and those need to be considered in a holistic approach. So examples of this include the finding that septal wall motion is evaluating relative pressure differences and will be underestimated in the presence of LV systolic hypertension, or potentially overestimated in the presence of LV systolic hypotension. Additionally, something like the tricuspid regurgitant jet velocity is affected by signal quality and may be underestimated in the setting of RV dysfunction. So let's start with the interventricular septal wall motion. So normally, as is shown on the left, the crescentic RV wraps around the circular shaped LV with the septum in between the two, in the peristernal short axis. So as the right ventricular systolic pressure increases, flattening of the septum in the end systole may occur as is depicted on the right. It's also important to note that qualitative assessment of septal flattening may be inaccurate. So to help us with this, the measurement of LV eccentricity index is used as an objective measure of septal configuration by dividing the horizontal diameter of the LV in end systole, shown in the figure as D2, by the vertical diameter, shown here as D1. In the usual round configuration on the left-sided figure, the eccentricity index is about 1. An eccentricity index of greater than or equal to 1.3 is indicative of an estimated RVSP of more than half systemic. So in the middle image, you can see that it's now a D-shaped LV in this case. So as the RV pressures continue to increase to suprasystemic, paradoxical bowing into the LV will be apparent, and the eccentricity index will continue to increase, and that's shown on the right. It is important to note, however, that using an objective measure is not foolproof. So optimal visualization in the correct plane is required for accurate measurement. So the images here were taken in the same patient within seconds, literally seconds of each other. So on the left, we see A and C, and the image is just not optimized. But let's focus on C, where you see that the plane is not quite correct. So you have one papillary muscle, but you also are seeing the mitral valve leaflet. So this off-axis image leads us to measure an eccentricity index of 2.05. However, when you go and you fix your plane, and you fix your image, you can see that in D, with the correct plane, which has both papillary muscles visible and no mitral valve leaflet, the eccentricity index is actually normal, and the septum is in fact round. So next, let's discuss the estimation of right ventricular systolic pressure through measuring the tricuspid regurgitant jet velocity. So the tricuspid valve is evaluated in multiple imaging planes in order to obtain the cleanest jet with the minimal angle of insumation. The modified Bernoulli equation is used to estimate the RVSP as a surrogate for pulmonary artery systolic pressure. So on the left, we see a color Doppler image. In the peristernal, this is the peristernal long axis plane with an easily recognizable TR jet. So when that jet is Dopplered with continuous wave, we get the image on the right with a near complete envelope and the ability to measure the RVSP using the equation. So in the setting of an incomplete or unidentifiable envelope, the accurate pulmonary artery systolic pressure estimation is not possible. However, this does not rule out significant pH. Additionally, it'll be underestimated in the presence of RV dysfunction as well. So when we think about the blood moving from the RV into the main pulmonary artery, the resistance encountered may change the envelope of the normally laminar blood flow. So in the setting of normal pulmonary vascular resistance, the envelope will be in the shape of an isosceles triangle, as is shown in A. I keep pointing, but I've got to use my mouse. So it has gradual acceleration and gradual deceleration. So the time to peak velocity of the Doppler envelope is the pulmonary artery acceleration time, the PAAT. So in this situation, it's almost directly in the middle of the envelope. And so when PVR is elevated, the RV must pump against higher resistance, resulting in more rapid acceleration of the blood flow, leaving the RV. So this envelope will change to resemble more of a right angle triangle. Who knew that we were going to be using geometry this far into our careers, right? So at this point, the peak velocity is much closer to the beginning of the envelope, and the ratio will increase, and that's shown here in B. So notching of the PA envelope in the deceleration phase may also occur due to high PVR, and that is depicted in C. It's always abnormal. So even if we measure a normal RVET to PAAT ratio, if we see notching of the pulmonary envelope, we will label it as elevated PVR. I turned my phone off to not get that, and it came on my watch. Some things you just can't prevent. Okay, so we're going to throw back for a second to remind ourselves of the changes of the heart with pulmonary hypertension. So the figure that I showed a little earlier, where you go from a normal heart with normal size ventricles and atria to the severe RV dysfunction over here with the dilated RA and the RV. And the reason is because now we get to see it in an actual patient. So as I said before, in the presence of the increased pressure, the RV may adapt by becoming hypertrophic and progressing to dilation, as we were shown in that figure that I just showed you again. So in these images, we start off with the normal RV, normal size RV, which then begins to become more hypertrophy as it's undergoing homeometric adaptation. So on the right-hand side, we see some hypertrophy and dilation on the top, and then progression to severe dilation on the bottom. And this is what we call the heterotropic adaptation. So another important image that we use in the assessment of acute pulmonary hypertension is the RV three-chamber view. So when in the correct position, the aorta is seen in the middle of the image as a circular structure above the RV, and it shows both the inflow and the outflow tract with the tricuspid and pulmonary valves opening and closing. So this is the RV three-chamber view right here. So fractional area change, or FAC, of the right ventricle can be used as a surrogate measurement of RV ejection fraction. So you can measure it both in the apical four-chamber view or in the three-chamber view, as we're doing here. So the reason that we use the RV three-chamber more often is because we think that it's less influenced by interventricular septal motion than the four-chamber view. And so in pulmonary hypertension, where you can have issues with that, it's a better view to measure. So we measure in end diastole on the top first, and then end systole on the bottom, and then use this equation to figure out the FAC. Normal values are greater than or equal to 35%. Tricuspid and annular plane systolic excursion, or TAPSE, on the left describes the apex to base shortening of the RV, or in other words, the longitudinal motion of the RV, which represents the main component of RV systolic performance. So normal values are going to vary, and that's based on gestational age, birth weight, and even postnatal age. So in the setting of RV dysfunction, the displacement will be minimal, and therefore the TAPSE absolute number will be low. So tissue Doppler imaging in the middle, or TDI, is used to measure the higher amplitude, lower velocity signals of the myocardial tissue motion as compared to the high frequency, low amplitude signals from red blood cells on conventional Doppler. So this also measures the longitudinal performance, similar to TAPSE as well. So strain over on the right, strain and strain rate, are measures of deformation that may help describe the nature and the function of the cardiac tissue. So strain is more helpful for evaluating global function, whereas the TAPSE and the TDI are more looking at regional abnormalities. So RVO, right ventricular output, represents the amount of blood that's ejected from the RV into the main PA with the equation as shown. So we obtain this from either peristernal long or short axis, and we use the one that has the best angle of inclination, and we want that perpendicular to the valve. So the annulus will measure at the hinge points of the pulmonary valve leaflets while open to obtain the pulmonary artery radius. The VTI is the velocity time integral from the Doppler tracing, and the heart rate is obtained while measuring VTI to calculate the outputs. So with disease progression, we've already talked about, it's not uncommon to see RV dilation. So one method of following RV dilation longitudinally is measuring the RV and the LV area in end diastole, and dividing the RV area by the LV area to get a ratio. Usually that ratio will be less than 0.5, definitely less than 1. But as the RV dilates, it will increase above 1. And so if we had measured this image on the left, it would definitely be greater than 1. So preload. Left heart filling can be assessed with the pulmonary vein Doppler. So in the apical 4-chamber view, the right lower pulmonary vein is usually well aligned for obtaining a Doppler with minimal angle of inclination. On the right hand side, top image, we see a normal pulmonary vein Doppler pattern. In the presence of pulmonary hypertension, however, we might instead see low peak pulmonary vein velocity as a result of decreased pulmonary venous return due to decreased pulmonary blood flow. So this is what we're looking at in the lower image here, where we see our pulmonary vein flow velocity is rather low, as this and this is the same scale. This is just the decreased pulmonary blood flow. And then flow direction across the PDA provides the most direct method of evaluating the relationship between pulmonary artery pressure and systemic arterial pressure. The presence of an exclusive right to left shunt is always abnormal, and that's what we're looking at here in the images, where you go kind of a sweep from the aorta over to the LPA, and you see the completely right to left PDA right there. So when the shunt's right to left are greater than or equal to 60% of the time, it indicates suprasystemic pulmonary arterial systolic pressure. So it's important to note that a pre and a post ductal oxygen saturation gradient will only be present if there's exclusive or almost exclusive right to left transductal shunt, and therefore absent gradient should not be translated to mean that pulmonary pressure is not pathologically elevated. You can also look at the PFO. So the presence of an exclusive right to left atrial level shunt or communication in the assessment of pH is always abnormal, and that should prompt further evaluation. So here in the image on the left, we see an exclusively right to left shunt through the PFO with color, and then pulse wave Doppler on the right. So on the other hand, a left to right shunt in the presence of high pulmonary pressures could signify increased left atrial pressure, pointing to pulmonary capillary wedge pressure as an etiology of your increased pulmonary pressures rather than increased PPR. So we all have heard of all of these medications, save maybe Rios. I'm not sure if everybody's heard of Rios. And these are the things that we talk about and use regularly in acute and chronic pulmonary hypertension. So in acute pulmonary hypertension, oftentimes we only use inhaled nitric oxide out of these. And then I want us to remember that there's also PGE down here towards the bottom that is a medication that we can use in PH with the failing RV. Okay, so some of you will know what I'm talking about or what I'm getting at when I say MVP. But the first thing I wanted to do is remind you of our own Iowa MVP, who was Regan Giesinger, who the conference is named after. And so she was a fantastic physician and hemodynamic specialist. And so one of the challenges that she absolutely loved was getting these ECMO consults or referrals from outside institutions who would send a baby who they're like, this kid has to go on ECMO. We don't have ECMO. We're sending them to you to put on ECMO. And it was, like one of her favorite things to avoid ECMO by practicing good hemodynamics care. So her approach to stabilizing the pre-ECMO patient, which turned into MVP, was that she would get rid of the wrong medications, essentially. So the ones that were not actually helping the physiology, she would use vasopressors, but most often vasopressin, sometimes norepinephrine, that would actually help with the pulmonary vascular bed and not harm it, not make it worse. She'd keep the PDA open. She'd add in milrinone once she got the baby stabilized and the blood pressure is in an appropriate range. And she would literally sit at the bedside and monitor all these changes with serial TnECHO until she felt confident that we had avoided ECMO. She was very good at that. So let's discuss vasopressin briefly. So I'm not going to go into a lot of detail about these things because I do want to leave time for some questions. So vasopressin in acute pulmonary hypertension, there's this study that showed an improvement in oxygenation index on the left with an increase in blood pressure with vasopressin infusion. And talking about milrinone in acute pulmonary hypertension, so studies have shown that it's also effective in reducing oxygenation index and FiO2 associated with better clinical signs and symptoms like increased urine output and increased pH, and then also decrease in INO requirement. And there's multiple studies of both vasopressin and milrinone in different populations. But for milrinone specifically in CDH, post-cardiac surgery, and acute pulmonary hypertension. But there's also the population of HIE patients who are undergoing therapeutic hypothermia, who we know also have sometimes intrinsic increased pulmonary vascular resistance that is then worsened once they are cooled. So in that case, there was a study that was done that showed that milrinone was actually associated with hypotension. So milrinone treated babies that have HIE and are undergoing therapeutic hypothermia are shown in red. And so systolic arterial pressure on the top left, diastolic arterial pressure on the top right. And you can see that those in the red are significantly decreased. Additionally, what they found was that they required an increased inotropic score, and so just a lot more vasoactives in order to help their blood pressure, essentially, because they became so hypertensive. So, so MVP, milrinone, for afterload reduction in inotropy, but we have to have caution in renal injury, therapeutic hypothermia. If there's other drugs that we might be giving that could cause a problem. So thinking thoughtfully about medications before we start them and making sure that there's not some relative or absolute contraindication. Vasopressin for systemic hypotension, sometimes norepinephrine might actually also be appropriate. But in the realm of using vasopressin in our MVP, we have to be mindful of hyponatremia due to natriuresis. Some of these babies can pee out a lot of sodium, and so we have to be on top of monitoring and supplementing as well. And then PGE for ductal patency. This is really just for those babies that are, and we're talking about acute pulmonary hypertension, so it should be neonates that are pretty early on in their course, and they should have a narrow or closed PDA. So the big question is, why not dopamine? A lot of neonatologists will say they feel most comfortable using dopamine because it's the most studied medication for blood pressure in neonatology, and I can't disagree with that statement. So let's look at a few selected studies. So in this case, this is looking at vasopressors and pulmonary circulation, and this is a neonatal piglet model. So these piglets, I was going to say babies, but these piglets were made hypoxic and then given dopamine or epinephrine. Dopamine significantly increased the pulmonary pressure above the baseline expected for hypoxia throughout the dosage range. So even at the lower doses. whereas epinephrine at a higher infusion rate, so at 0.1 mics per kilo per minute, which is higher than we normally use in our patient population, did increase, but did not increase pulmonary pressures to the same extent. And you can see up on the top that it actually had a change in LVO, whereas you didn't see that in the dopamine treated babies, piglets. So another study looking at dopamine plus high dose epinephrine or high dose dopamine. So in this study, the low dose dopa with the epi and the high dose dopa increased blood pressure, but also increased pulmonary artery pressure, which is in the middle. So here's your mean arterial pressure, pulmonary artery pressure, and then the ratio of the two. So it changed the ratio in an unsatisfactory way. So the paper that I sent out to you guys to kind of go over, you'll recognize this figure, both figures. So in pulmonary hypertension, dopamine kind of intensifies the negative effects of the increased pulmonary pressures by further augmenting those things. So, the acute pulmonary hypertension causes a lot of this stuff, but then dopamine will then increase your pulmonary vasoconstriction more, increase your PVR more, which increases your afterload more. And it could have worsening of the right to left shunt at the PFO to PDA. The increase in heart rate might increase your myocardial oxygen demand, et cetera. So it just can add to a lot of things. So on the right, the figure on the right, in control lambs, so again, another animal study, the controls were in red. There is a selective increase in systemic, so systemic versus pulmonary artery pressures, which increased the systemic to pulmonary artery pressure ratio, but there was not a change in oxygenation. However, when you look at the lambs who had acute pulmonary hypertension, so those are in blue, the lambs that had pulmonary hypertension, their pulmonary artery pressures here in the dashed blue were actually higher and much closer to their systemic pulmonary pressures to begin with at baseline. And then when you added any amount of dopamine, those get significantly increased as well. But here you see that the ratio didn't actually change. So it increased both the systemic and the pulmonary artery pressures, same amount. And then there was no significant change in the PaO2 as well, the oxygenation. Okay, so to be fair, we have to talk about norepinephrine as well. And so we talked about MVP being the vasopressin, but sometimes norepinephrine might be an alternative that you can use. However, it probably is also a vasoconstrictor, a pulmonary vasoconstrictor, at least in certain situations. So here on the left, this study was looking at patients in newborns in 100% oxygen versus those that are controls. And you can see that in 100% oxygen, norepinephrine increased the vasoconstriction of the pulmonary arteries more significantly. Here on the right, you have a study where they actually use milrinone to decrease both the pulmonary and systemic vascular resistance. And so then you kind of had this significant drop here in the after milrinone. Then you started either norepinephrine or terlipressin, which is the vasopressin analog. And so the norepinephrine is here in the light gray, whereas the terlipressin is in the dark gray. And you can see that they both increased your SVR, which was something that is desired. However, the norepinephrine actually increased your pulmonary vascular resistance, whereas the terlipressin did not increase the pulmonary vascular resistance. Okay, so now let's apply what we've discussed so far. So we have a 25-week premature infant who had PPROM since 17 weeks gestation, initially required 100% FiO2, was intubated, got surfactant, that improved things to 50% FiO2, but then got significantly hypotensive. So systole is in the 20s, over diastole is in the 10s, in the teens. And slowly the FiO2 kind of increased back up to 90%. So hemodynamics consult was asked for, and what they saw was moderate RV dysfunction. So here's your RV FAC and your TAPC. So your TAPC was low and your FAC was low as well. And here on the left, you can see another sweep. So we do a ductal sweep from the aorta to the pulmonary artery, and you can see the PDA briefly, all right to left. And then on Doppler, you can see that it's all right to left as well. So now we have a controversy, right? So there's a Cochrane review out that says that ultimately INO should not be used for respiratory failure, hypoxic respiratory failure in preterm infants, that it doesn't appear to be effective. And some of the problems with this review is that it's looking at a bunch of different studies. So trials of babies in their first days with severe hypoxic respiratory failure, but also some that are at risk for chronic lung disease, and then also trials providing early kind of preventative therapy. So it's a mixed bag. However, looking really closely at the studies that they did include, we see that there actually was an improvement in oxygenation in most, if not all, of the studies that evaluated this as an outcome. So there were several studies here, and then one that looked at pulmonary artery pressure. So we have to go back to my first slide of why would that be? So do we think, or are we making sure that we're treating the right pathophysiology? So I will mention one study that our group did where we looked at premature infants who received inhaled nitric oxide for hypoxic respiratory failure, and categorized them into responders, non-responders, and a new concept of negative responders, meaning the baby clinically worsened after INO initiation. And in other studies, these are usually lumped in with the non-responders, which makes it seem like there's fewer responders. However, babies who were negative responders, in the gray color here in the figures, were more likely to have PDA or sepsis physiology, not pulmonary hypertension. So that's not quite a shocker, right? When we say that INO isn't working in preemies, it's possible that we're not treating pulmonary hypertension in these preemies. We're trying to use INO to treat some other pathophysiology that it's not meant to actually improve. Okay, so back to our baby. So 2 hours after birth, had suprasystemic pH, mildly elevated RV, moderate RV dysfunction, mild LV systolic dysfunction, and a large PDA with right to left shunt. So we went against the Cochrane review and we treated with nitric. We also added some dobutamine for the dysfunction, and then there was some vasopressin added as well. And the baby's FiO2 improved to 40 to 45%, and then continued to kind of slowly improve from there. So we got an echo again less than 12 hours later, and this is what we actually saw. So you can see the septum, and again, qualitative measurements or assessment is not reliable, but it looks rounder. But here you can see the arch, the LPA, and the duct, and now, I mean, you can't miss that duct because it's mostly red. You can see that it's a little bit bidirectional, so it's mostly left to right at this point. So the other question is, when you do have a bidirectional or right to left PDA, is it always pulmonary hypertension? So this goes back to kind of something that we talked about early on. So you have a small baby, a 23-weeker, who's on the jet ventilator with the MAP of 15, but requiring 100% FiO2. Blood pressure is 50/35. Here's your pulmonary vein flow, and you can see that it's pretty low. Your EF is okay, but your TAPC is not. It's pretty low. Your LVO is low. Your RVO is low. Your RVET to PAT is elevated, and then your eccentricity index is elevated as well. So just take a second. Do we think this baby has increased pulmonary vascular resistance or not? And so green means go. You have suprasystemic pulmonary hypertension, decreased RV systolic performance, and low cardiac output with a high PVRI and flat septum. So baby needs some pulmonary vasodilation and inotropy. This 25-weeker had PROM at 8 weeks. FiO2 is 40% and BP was 25/11. So now when we look at pulmonary vein flow, we see that it's there. It's not low. Your EF is 70, your TAPC is 5.7, which is in the okay range. Your LVO is 238, RVO 216, RV to the PAT is in the normal range, and your septum is round. So no. So normal biventricular systolic function with normal cardiac output, no pH, normal PVR, and a bidirectional PDA that's actually due to severely low SVR. So this kiddo needed treatment with vasopressor and volume. So now you have a term infant with HIE who is undergoing therapeutic hypothermia, has signs of low cardiac output state, preductal sats 91, postductal 55, is requiring 100% FiO2 and has cardiomegaly on X-ray. So if you take a look at this, does this look like one of our acute pulmonary hypertension figures when we go back to the adaptation? So I'm going to say yes, but then you look at this next image, and that does not look normal. So this is supposed to be looking at the arch, and you can tell that there's an issue there. So congenital heart disease, and specifically left-sided structural issues, will increase your pulmonary capillary wedge pressure, excuse me, which will look like pulmonary hypertension, or is pulmonary hypertension. It will increase your pulmonary pressures. However, it's not due to increased PVR, and it's not treated with pulmonary vasodilators. So we actually can make things worse if we start with pulmonary vasodilators in this situation. And then another one who was a term infant, acute hypoxemia, cardiomegaly on X-ray, again, signs of low cardiac output state. And just look at the images and see if you think that anything is abnormal in these images and what you'd be concerned about. And let me tell you that the flow is high, the RV is not great. And of course, the PDA again is bidirectional, 70% left to right. So at 60%, if you remember, we said that's suprasystemic pulmonary hypertension. So you have suprasystemic pulmonary hypertension in this patient with low RV function, and this is your SVC, so a dilated SVC. So, what would this baby? What would you do? I know we're not asking questions because it's being recorded, but in this baby, we would look for a reason why there's actually retrograde flow here in the aorta. So I'm not sure if anybody else noticed that, but usually you have nice laminar blue flow. This one you have red flow kind of going back up towards the brain where there's a vein of Galen malformation. So this still looks like pulmonary hypertension. And if you get a cardiology echo, oftentimes they will tell you you have pulmonary hypertension because your PDA is more than 60% right to left. However, again, if you started pulmonary vasodilators, that is not actually the correct therapy for something like a vein of Galen or usually a flow-driven pulmonary hypertension, because it could actually worsen the underlying physiology. So the paper that I sent out also had this little algorithm that I think is the starting point for everybody to kind of use. So if you have what you consider to be acute pulmonary hypertension, the first thing that you should do is try to confirm that diagnosis and confirm that that it's not actually LV dysfunction or increased pulmonary capillary wedge pressure or increased pulmonary blood flow that's causing the increased pulmonary pressures. And then go down, do you have RV dysfunction? Yes or no. Do you have hypotension? Yes or no. And kind of go based on the clinical scenario and what you're finding on your echo as well. Okay, so in conclusion, ECHO is an essential tool in diagnosis, stratification, and longitudinal care of patients with pulmonary hypertension. It's essential that high quality imaging is obtained in order to maximize the accuracy of the information that you get from the physiology, and then comprehensive imaging with quantitative rather than qualitative evaluation is important to ensure phenotypic precision and to select the appropriate management strategy. And so I'm part of a great hemodynamics program here at Iowa, where we have 5 faculty and we do greater than like 1,500 consults per year, and actually have a fellowship program as well. And we've recently renamed it after Dr. Giesinger, who passed away earlier this year. And happy to take questions.
Thank you very much, Danielle, for that fantastic talk. And you went through some very interesting cases in just a couple of slides. I have a feeling there are going to be some questions to kind of
But only talk for 40 minutes, right?
That's right.